So, I thought this would be an interesting topic, just because we get a lot of women now, a lot of women now who are conceived with IVF, and a lot of them want to know, is there increased risk for my pregnancy? A classic example is a 32-year-old woman, a few years trying to get pregnant, unexplained cause, it's not her partner, 3 cycles, conceived with a frozen embryo, and she wants to know, are there any increased risks for my pregnancy? And what do you tell her? Do you manage your pregnancy any different? Or maybe a 45-year-old, first pregnancy, she's 12 weeks pregnant, donor egg. Are there any increased risks for her, and do you manage it differently? Because she's 45. Should she be under midwife? Should she be under obstetrician? Should she be in the hospital? And what are the risks for her? So this is what we're talking about, and this is how I simplify it in my head. I'm not a fertility expert, but we stimulate the ovaries, and then we grab some eggs with it's a needle, a transvaginal needle. They go and retrieve some eggs, and they mix it up with some sperm, and they put it back in the uterus, and then you have a baby. But we all know it's not like that, and it can get a bit more complicated, especially in those older women. They don't quite conceive, and you have to have a donor egg and all that other stuff. And there's quite a bit of science to it now, and it's quite a highly specialised area. But, you know, it's not as easy as that. Significant, you can't really see that well, can you? But there's significant complications arise when there's more than one baby. And this is an example, 1, 2, 3, 4, 5 babies conceived after a stimulator cycle. She was given clomiphene, her cycle wasn't monitored, and then she hit the jackpot. So a lot of the big risks arise if you've got more than one baby, but most commonly there's one, and so that's what I'm going to talk about today. There's been a huge move about monitoring cycles, so we avoid stuff like this. So it means if you've got multiple follicles on your ovary because they've been stimulated, they ride the cycle, they coast it. They don't put anything back. They say avoid sex, use contraception, don't get pregnant this cycle, wait, not 1 but 2 cycles. And for someone who's trying to get pregnant or pushing time, that can be quite difficult for them. But, you know, as we mentioned before, some women are exquisitely sensitive to hormones. There's also a move to put back 1 embryo rather than a whole lot. The problem with IVF research or assisted reproduction research is there is many individual factors and they overlap quite a bit. And how do you know whether it's the woman, her medical conditions, or whether the fact that she's infertile is a problem? And that's the biggest thing to try and take out, is whether it's the infertileness that's the cause rather than something else. It's quite difficult to isolate, and a lot of the research showed a lot of risks a few years ago, but now the statistics and the analysis has got a bit more fancy, and they've been able to try and get those out. They're even subdividing into this type of assisted reproduction as well. So whether it's a frozen embryo, so they've had a fresh embryo, you put that back, or whether they've stored a few embryos and they've, well, it sounds funny, thawed them and then put them back, or whether they've just stimulated a cycle and you try and, I suppose, a bit more naturally. But there are some evolving trends, and I'll talk about each one of them. Preterm birth, low birth weight, maybe birth defects, placental associated disorders, and imprinting disorders. So preterm birth, most studies will say that there's a risk of preterm birth. So preterm birth is delivery before 37 weeks. There's a risk of around about 2-fold compared to the general population. But the contribution of spontaneous, so someone who goes into labour laterally versus iatrogenic delivery because she's got complications, is unknown. Interestingly, similar risk factors as the general population for preterm birth, so first pregnancy, smoking, and you'd hope that they weren't smoking if they've had IVF, because that's one of the criteria for receiving IVF in New Zealand. A BMI, again the criteria in New Zealand, BMI less than 30, hopefully, well at least for funding. And vanishing twins, so you could see a twin pregnancy and then early on it just vanished.
And what about low BMI?
That hasn't come out in the IVF studies, but it is a risk factor for preterm birth in the general population. But you can't, they don't know whether it's age and low BMI or socioeconomic status and low BMI. Low birth weight, relative risk of about 2 as well. And small for gestational age is defined by less than the 10th centile. Again, they don't know what the underlying cause is, and it's not necessarily related to the placenta, but they don't know whether it's related to other things. Again, smoking, BMI, maternal age. And BMI can go either way, high or low. And maternal age, advanced maternal age. And duration of infertility. So the longer you're infertile, the higher risk of a low birth weight baby. Fresh versus frozen embryos. If you conceive on a frozen embryo, you'll most likely have a higher birth weight baby compared to a fresh embryo, and you have a reduced risk of small for gestational age and preterm birth, which is quite interesting because intuitively you'd think the fresh would be better. But with a fresh cycle, they do use a lot of hormones, and they stimulate the endometrium, and they stimulate you to get the eggs out, and then they put them back on that cycle. It's a very short space in time. In the frozen one, a lot of the times they're putting you back on a natural cycle, or there's less hormonal stimulation to the endometrium, and they think that's what the cause is. So there is a difference. It's a frozen. Yeah, there's a lot of mixed results when it comes to birth defects. The latest meta-analysis in 2012 was published in the New England Journal of Medicine, shows there's no association. They look for every confounders. Now this is just an example of birth defects that came out in previous studies. Genital organ malformation, septal heart defects, esophageal atresia, anorectal atresia. And in some studies, look, the adjusted odds ratio is 4.5, so it's huge. And then to go from that to no association is quite interesting. So as far as I'm concerned, the jury's out at the moment. Placental association disorders. So these are all disorders associated with abnormal placentation. Obstetricians are quite keen about placentas, especially fetal medicine specialists. There's a lot of reason why the placenta doesn't implant properly. It can be older, pre-existing medical conditions such as high blood pressure or diabetes, or younger, smoking. So these are all disorders that can be related to abnormal development of the placenta. Low birth weight doesn't come out as related to the placenta, and it's thought that it's multifactorial rather than relating specifically to the placenta and IVF. Preeclampsia, no association, surprisingly. But placenta previa, yes. And that's there's adjusted odds ratio of 2.3 for that. So yes, there's a higher rate of placenta previa, so a placenta that's low to the cervix. There's advanced maternal age is noted to be a risk factor for placenta previa, but after adjusting for it, that still is apparent. And it's hard to know whether it's due to that maybe it's implanted a bit low, but it probably plays into it.
On the handout slide, you've got placenta.
I know, I changed it, sorry.
Okay.
There's no association with accreta. So you can cross that out. Antepartum hemorrhage, yes, there is an association, and again that's an odds ratio of 2, and there's a slight increase in postpartum hemorrhage of 1.3. These are all adjusted odds ratios. Vasa previa, Vasa previa is a condition where the fetal vessels lie in close proximity to the internal cervical os. And when I say close proximity, there's no definitive measurement away. So with placenta previa, if it's over 2 centimetres away from the internal cervix, it's high. Vasa previa just has to be in close proximity to. There's been no numbers put on it. And here's a picture here of it. So this is a placenta. This is the cervix here. So that's the cervical canal. So the placenta is adjutting that cervical canal. And that's a cord insertion. So the cord insertion's coming off laterally on the placenta. And here's the fetal vessels here. So this is a high risk pregnancy, and if those vessels rupture, the baby exsanguinates. And a baby has a small blood volume, so it's 80 to 100 mils per kilo. So if you think about a 28-weeker, a 28-week is about a kilo, so 100 mils of blood. 100 mils of blood's not much. If they lose 20 mils, that's 20% of their blood volume. So what I was getting to is it's so important that our college, the Royal Australian College of New Zealand, this one here, and also the Canadian College have got guidelines for the management of vasa previa. Now if you're after good guidelines, the Canadian guidelines are very good and they're very comprehensive. These guys are the only one that will talk about inpatient monitoring, and they talk about admitting these women from 30 weeks to delivery. Ours is a bit more vague. It's practitioner dependent, I think is the word. So anyway, the background rate in vasa previa in the general population, 1 in 2,200. In the IVF population, it's 1 in 200. And because of that, there has been a movement, maybe some whisperings about universal screening for vasa previa in the IVF population. So that means a transvaginal scan at 20 weeks to screen for this condition. At the moment, when you have your 20-week scan, they'll do a midline image of the uterus, they'll put some colour overlying the cervix, all that area, and that will be it. So that's probably going to be the biggest change, universal screening for vasa previa. Imprinting disorder. Imprinting is a very difficult thing to explain, and you probably have heard about them. So Prader-Willi, most people have heard about Prader-Willi. That's an example of an imprinting disorder. So usually you inherit 2 genes from each parent, so 1 from each parent, and they're both active. In an imprinting disorder, you get both the genes from one parent, and one of those is deactivated. Prader-Willi's one of those. And Angelman's, it's opposite, depending on which parent inherits it. So imprinting occurs at a higher rate in the IVF population, but the actual rate's low. But we don't know why. So the mechanism for it is unknown, but it's interesting research. But you know, the overall risk is less than 1 in 5,000, so it's not worth screening for it.
But with an embryonic approach, would any of those come up in an embryonic screening approach? If you know that this is a...
Yeah, so Beckwith-Wiedemann, you would pick up, it's an overgrowth disorder, so you'd a macrosomic baby, large organs, protruding tongue, and phalloceal usually. So you pick it up that way. So from a fetal...
embryo screening?
No, PGD's got its own risk, and it's probably out of the scope of this, but they wouldn't, it's not worth doing that. In fact, they did a lot of research with, so PGD's, when you've got a whole lot of cells at the early stage, you take out one of the cells and you test it genetically. And they did that for Down syndrome a while back when the advanced maternal age, but it's inherent risks associated with it. But these are so specific to lesions, you have to really look for it. It's a specific genetic test, and at the moment they don't have a genetic panel for that. You know, it'd be nice to have a genetic panel to say, this is the imprinting disorders we're screening for, these are the other disorders we're screening for. But you know, they may get there, especially with the advent of non-invasive prenatal testing. There's a lot of work with that, so getting the fetal DNA through a blood test. and then testing for that. And we did start off with screening for Down syndrome, but it's rapidly expanding for other types of syndromes. Overall approach, be aware that there's a 2 times risk of preterm birth. There's a risk of low birth weight, so their trimester growth scan, or do your customised growth chart. Is normal screen for preeclampsia, ultrasound look for growth, abnormal implantation, at the moment congenital abnormalities, but they're screened for anyway in a routine pregnancy, and consider screening for vasa previa. So again, some guidelines. This is a scientific impact paper by the UK Royal College of Obstetricians and Gynecologists about IVF and perinatal risks and early childhood outcomes. It talks about everything I've described. But it also talks about the Barker hypothesis, in utero environment programming, and whether that means there's a risk for the child later on. So classic examples, a small baby starved in utero comes out in childhood risks of high blood pressure, diabetes, cardiovascular disease, that type of stuff. Whether it's the IVF or whether it's the growth restriction. But it does talk a little bit about that. Pregnancy outcomes after assisted reproduction. It's a really nice summary, and all of that's what we've just talked about. So I thought I'd talk about advanced maternal age, basically because I felt that topic we just talked about didn't really say that much, and I thought this is quite a bit more interesting, and I think this has inadvertently become a special interest of mine. I see the woman over 45 for consultations to discuss the risk of pregnancy before they become pregnant, and to screen them for medical disorders to see whether it's safe for them to become pregnant. It also goes through a national ethics committee if they're 45 and want to donate egg. So we have to tell them it's safe, whether it's safe or not for pregnancy, and whether there's any underlying risk factors, and they need to know the risks, which are lowish but significant. Now there aren't many papers about extreme advanced maternal age, and extreme advanced maternal age is those women over or equal to 45. But this paper is very good. It's in the American Journal of ONG. It's a nice demographic natural history paper. It describes what's going on in the population, and it talks about the outcomes. So this is a table, this is a summary of it, but this is a table, and you've got a copy of that I give the ladies preconceptually. I think it's a nice summary just to say, there's a high rate of gestational diabetes. We should be screening you for it and watching you closely in your pregnancy because of that. There's a higher rate of high blood pressure, preeclampsia, placenta previa. You're likely to deliver less than 37 weeks. Higher rate of caesarean delivery. Slightly higher rate of small for gestational age baby. And there's a significant, I didn't talk about the neonatal ones, but there is a slightly higher rate of admission to the neonatal unit, but that's probably related to the preterm delivery rate. Now, I don't know whether you've noticed, but there's definitely a growing trend to inducing older mothers, and older, only 40, so it's not that old. So a woman over 40 by their due date, so not letting them go too far overdue. This is a very good scientific impact paper, Royal College of ONG, and it talks about the rationale for it. And if you have a look at the table here, this is the stillbirth rate. So 25 to 29, the absolute risk is about 1 in 200, but over 40 it's 1 in 130. So there's a higher risk as you're getting older, but a 1% chance is still okay. So based on these statistics, you'd have to induce an extra 4,750 women at 40 weeks to prevent 17 stillbirths. So that's not good medicine. But you have to take into account the bigger picture. And it talks about the individual rates in that paper, but it's very good. And when you say you've got just under a 1% chance, that's still all right. So this is my own advanced maternal age protocol, preconceptual counselling, outline the rest of the pregnancy, rule out any underlying medical conditions, so thyroid functions, diabetes, anything like that, and any type of clues. Start them on folic acid. Booking scan. Booking scan, confirm the dates, makes it easier at the other end. Low dose aspirin to help placental implantation, lower the rates of high blood pressure in small for gestational age babies. A booking HbA1c or a fasting glucose, depending on what you want to do. I always do thyroid function tests, but usually if the IVF, they do get screened for subclinical hypothyroidism. Aneuploidy screening, now that relates to maternal age, but if they've got a donor egg, it'll be based on the age of the donor. So a lot of them do have quite young donors, younger. So you can do combined first trimester screen. You can do a non-invasive prenatal test, and it is available. It's an advanced screening test, but most people will act on that. And invasive testing, some will just go straight for a CVS or an amniocentesis. And I think that's reasonable because it's a diagnostic test rather than a screening test. If they're older, you know, if they're 45 and they've got a baby with Down syndrome, that child, you know, the average age is 52 life expectancy for a Down syndrome child, so they are on the older end of the spectrum. But again, it's all you know, part of your preconceptual counselling. Do they want to know what would they want to do about it? These are the options. Now, it probably shouldn't be a polykose anymore. It probably should be a glucose tolerance, and I think it's just changed in July. Ranscock have recommended a glucose tolerance instead of a polykose, and that's because the polykose has a 20% false negative rate, so we're missing 20% of people with diabetes. Preeclampsia screening, detailed anatomy scan, consider ruling out vasa previa, 24-week uterine artery Dopplers. Now I'm quite lucky because I can scan my own ladies and do uterine artery Dopplers, but and again, it depends on your local services. But uterine artery Dopplers measure the blood flow to the uterus. We do it at 24 weeks. Those that have high resistance or notched will have a 50% chance of a small for gestational age baby or preeclampsia. And while we can't do anything about it, it gives us more information. And hopefully you've got her on aspirin and it doesn't matter. The serial growth scans. And the frequency of those, 4 weekly, or it can be directed by uterine arteries as well. So if the uterine arteries are normal, I'll do one at 28 weeks and then one at 34 weeks. If they're abnormal, depending on the growth of baby, fortnightly or monthly. Now this is controversial. Serial CTGs from 37 weeks. Now that comes from the Canadian guidelines, who recommend serial CTGs from 37 weeks, as well as ultrasound and consideration of induction of labour from that stage as well. They're very aggressive in their management of this age group. But I think it's probably reasonable, if everything's going well, to deliver by the due date and in some cases consider an elective caesarean section. It's important to remember that although the risks are increased, the absolute numbers are quite low.
Is this all for assisted conception or all older women?
All older women. This is what I do for all older women.
Over 45.
Yeah, it sort of blues between the 40 to 45, but I'll take into account all risk factors. It's quite a good guideline for that, and considering the numbers will increase proportional to age. Yeah, just depends on what's going on. I think a 40-year-old multip's different than a 40-year-old primate. Depends what other medical conditions are going on. Maternal cardiac, yes I do. So I do cholesterol levels, and we see the blood pressure and listen to their heart. I don't do ECGs myself, but I do biochemical screening. Yeah. And that's one of the main drivers for the preconceptual counselling in Australia. And there was a woman that had a donor egg, she went through IVF, she had a high BMI, had a heart attack and died. And so now everyone who is at risk over 45 at risk over 40 or over 45 is recommended to have preconceptual screening either with a fetal medicine specialist or a medical physician with an interest in obstetrics to talk to them about the risks in pregnancy. And I think that is quite a medical legal approach, but because IVF's a private service, I think that's the way it's going. And definitely there are some women who go over to the States and that's part of their requirement, that a fetal medicine specialist has signed that and gone through the risks with them.